Good evening, everyone, and a very warm welcome to today's session. I am Arpita from the IGCP group. Now, alcohol use disorder, it continues to be a major clinical and public health challenge affecting not just physical health but mental well-being, families, and society at large. With evolving evidence, newer therapeutic approaches, and a growing emphasis on holistic care, it is important for clinicians to reflect on whether we are managing alcohol use disorders differently and more effectively today. So, in today's session, we are going to discuss on the topic managing alcohol use disorder today. What should clinicians do differently? And to guide us through this very important discussion, we are privileged to have with us our host, moderator, speaker for today's session, Professor Dr. Shubhangi Parker, ma'am. It's an honor for us to have ma'am in our platform, and she has not come alone. She has bring her team with her today. So, ma'am is ex-dean and academic dean of SET GS Medical College and KEM Hospital, Parel, Mumbai. Ex-dean of Vedanta Institute of Medical Science and also an ex-chief of De-Addiction Center of Excellence, KEM Hospital, Mumbai, and advanced level yoga therapist and a cognitive therapist. So, ma'am, now I would request you to please take over the session. Over to you, ma'am.
Thank you. Thank you, Arpita. We have to probably very got into a very important topic. Good evening, everyone. What should clinicians do differently? Alcohol use remains one of the leading, yet often underestimated contribution of the global disease of the burden. According to WHO, 2.6 million deaths worldwide were attributable to alcohol consumption in the year 2019. 2 millions were men and it is important that WHO found the highest alcohol related mortality rates in European and African region, each recording over 52 deaths per lakh population. Beyond these numbers lies a more troubling reality. Alcohol addiction is a chronic and relapsing disorder characterized by compulsive alcohol use, loss of control over intake, and a negative emotional state when alcohol is perspective. Underdiagnosis in routine clinical practice, especially in non-psychiatric setting, is a common phenomena. Missed opportunities for early intervention, particularly during primary care or general hospital visits, is again noted phenomena. And a persistent misconception that alcohol dependence is a difficult disorder and is impossible to treat. So, in reality, alcohol use disorder or alcohol is treatable condition, and early identification can significantly alter its course. So, and there is a special concern also. Alarmingly, young adults aged 20 to 39 years are disproportionately affected, accounting for approximately 13% of alcohol attributable deaths globally. So, we have a very good panel, experienced panel, who has treating and being trained in this area, and for long many years they are in clinical order. So our first panelist, we will call Dr. Rupali Shivalkar. She is currently working as the head of the department secretary at St. Stephen Hospital, Delhi, and also serves as the medical director of Shanti Home Psychiatric Rehabilitation Center, Greater Noida. She is a visiting psychiatrist at National School of Drama and an ex-faculty member at the Institute of Human Behavior and Allied Sciences, Delhi. Dr. Shivalkar has also served as a teacher faculty for MD Psychiatry and MPhil Clinical Psychology under Delhi University, We are privileged to have her with us today, and I request Dr. Rupali Shivalkar to talk on the topic understanding the magnitude and core concept of alcohol use disorder. Dr. Rupali Shivalkar.
Ma'am, I think there is some network issue with ma'am. So let her join. Meanwhile, can we take the next speaker?
Next speaker we can go. Oh yeah, okay.
Ma'am, kindly introduce the next speaker, and once
Yes.
Rupali ma'am is done, we'll take her.
Yeah, basically, see, alcohol consumption is known to play a causal role in more than 200 diseases, injuries, and other health conditions. Alcohol use is strongly associated with a range of non communicable diseases, including liver disease, cardiovascular disease, and various cancer, as well as mental health and behavioral conditions. That is common mental disorder. Given this wide spectrum of harm, alcohol use clearly represents a major public health challenge with significant clinical implication across medical specialty. With this perspective, it is my pleasure to invite our second panelist, Dr. Neelam Behere, who will speak on clinical problems and complications of alcohol use. Dr. Neelam Behere is a research fellow in the Clinical Research and Training Program under DBT Wellcome Trust India Alliance and works as a consultant psychiatrist. She is trained in higher medical education, holding an MD in psychiatry, and has over 8 years of experience as a public mental health researcher and implementer, as well as practicing psychiatric clinician. She has mentored medical and public health graduates and postgraduate, authored numerous scientific papers in peer-reviewed journal, and has a strong interest in improving access to mental health care, particularly through resource-effective primary care level solutions. We look forward to her insights on the clinical complexities and complications related to alcohol use. Dr. Neelam Behere, over to you.
Thank you, ma'am. Many thanks for your introduction and many thanks for inviting me, having me here on this panel to talk on this very, very important, pressing issue of alcohol use disorder. Uh, uh, this is the second topic in the panel, and I would be discussing a little bit about clinical problems and complications of alcohol use. Since we all are practicing, we practice medicine, we come across alcohol use disorders, patients who have history of alcohol consumption currently or in some point of time in their lifespan. It is very important that we understand how we look at this problem. What are the particular issues that we need to check physically and mentally if we get a history of alcohol use? So, here it is. Alcohol related morbidity is virtually all, it affects virtually all organs. So, name an organ and alcohol affects it. It has been said that around 200 different diseases can have a causality with alcohol. So alcohol directly or indirectly causes 200 or probably even more injury related and medical complications with its effects. Uh, can we have this in a slideshow?
Yes, ma'am, you need to go to the next slide. This arrow button.
Okay. The animations won't run. Is that so? Okay, no problem. Let us not wait over here. It is important to understand how alcohol, in its acute and chronic effect, uh, chronic way, affects our body. To understand this, let us understand the spectrum. I'm sorry because the animations are not working, but I had intended to first show you what alcohol intoxication means. So, anytime an individual consumes alcohol, may that be a chronic alcohol user or a first time alcohol user, there are certain signs that we see physically and mentally, which we call as alcoholic intoxication. It is seen immediately after consuming alcohol. What are these effects? I have presented this in on the left hand side table, the different concentrations, the blood alcohol concentrations at which different effects are seen. It is a range of physical and mental symptoms that we see after immediate consumption of alcohol. Like for example, it begins with excitement, Then a little bit of serious intoxication where there would be slurred speech, incoordination, nystagmus. A little later, around 300, 350, hypothermia, dysarthria, cold sweats. At higher concentrations like 350 to 400, coma. And beyond that, it may be life threatening. This is almost invariably seen in all individuals who consume alcohol, and it's seen immediately after alcohol. Now, what happens is, if individual continues to take alcohol in larger amounts with tolerance and on a daily basis, where the frequency is increasing, the type of drink that individual is consuming, where the alcohol concentration is gradually increasing, we get to see a dependent syndrome where you see tolerance, like lesser quantities of alcohol doesn't create an effect, and hence and the individual has to take higher concentrations. Another essential feature of alcohol dependence is withdrawal symptoms. For example, if an individual is now primed to take alcohol in a particular amount and he gets particular effects, if he doesn't consume alcohol on a given occasion, he gets some withdrawal symptoms. So withdrawal symptoms may be seen uh, ranging from 6 hours to 24 hours. So those who have higher frequency or higher quantities of alcohol consumption, withdrawal features may be seen as early as within 6 hours of last alcohol consumption. What are the common symptoms that we see? One, physically, we see sweating, clumsiness, headache, shakiness, loss of appetite. There is constant restlessness, the heart rate increases, the blood pressure increases. Some may see fever or increased rise of temperature, which gives them chills or shakes, and also dilated pupils. You also see some psychological conditions like anxiety, nervousness, irritability, intense worry. You also see craving as a part of psychological withdrawal symptom. These may be little manageable. We can say that on the spectrum of mild to severe, these could be mild to moderate. But sometimes severe alcohol withdrawal symptoms may also be seen. One very important, very important alcohol withdrawal sign that we must be checking and emphasizing on is delirium tremens. Why am I saying important? Because it can be life threatening. How is it seen? It's a severe form of alcohol withdrawal where you see confusion, disorientation, hallucinations, agitation, stupor, sometimes in unconsciousness. And mind you, this can be life threatening. So immediate attention has to be given to delirium tremens. You also see alcohol withdrawal seizures, especially within around 24, say 1 day of alcohol, stopping of alcohol or last consumption of alcohol. Both these conditions are medical emergencies and they need immediate medical attention. How do we treat this or how do we address this? We would be seeing in the subsequent sessions. Moving ahead, it's not just acute effect or it's not just withdrawal. If alcohol consumption is continued for a longer duration, as we all know, we see a host of issues or complications, both physically and mentally. Of chronic physical effects of alcohol, many of us are well aware. We have seen patients daily in and out. So the list goes on exhaustively. As I said, you name an organ and there would be some ill effect of alcohol seen in that organ. So I would just quickly run through or mention these effects. For example, most popularized is gastrointestinal side effects. Or every individual who consumes alcohol knows that liver kharab ho jata hai. So what exactly it means? To quickly mention, it can cause fatty liver, cirrhosis, portal hypertension, and hematemesis. It can also cause gastric ulcers, peptic disorders, which is very commonly seen. It's a very frequent occurrence in OPDs where individuals say that I have acidity, and when we dig out it deep into the history, we see that they do consume alcohol. Malnutrition again is a very common occurrence after on chronic use of alcohol. Again, the symptoms resultant because of malnutrition are very common, like tingling numbness in hands and legs, neuropathies, wasting with multiple vitamin deficiencies and their subsequent effects. You also see decreased immunity resulting in infectious disorders. Very commonly, tuberculosis and alcohol use disorders are seen epidemiologically go hand in hand in Indian population. Trauma secondary to the intoxication effects or the psychological effects that we are going to see. So, getting affected by accidents or getting into fights, crimes, and the trauma that is resultant because of the physical trauma that is resultant because of it, again, is very common with individuals of alcohol use disorder. In pregnancy, alcohol has got many-fold larger effects, many-fold issues, particularly when because it gets transmitted across the placenta into the fetus. We see both maternal and perinatal and neonatal complications like low birth weight, intrauterine growth retardation, and multitude of problems like these. Cerebral cardiovascular disorders, of course, because alcohol affects metabolism, it can cause hyperlipidemia, it can increase weight, it can cause obesity, and the resultant cardiovascular complication like ischemic heart disease, cerebral vascular diseases. Important to mention here are the neurological complications. And I can't get off without having a mention of Wernicke's encephalopathy, which is commonly seen because of alcohol, particularly because of nutritional deficiencies of particular vitamins. What do we see in Wernicke's encephalopathy is confusion, ataxia, nystagmus, gaze palsies. Many times there is profound anterograde memory loss and a mild retrograde memory loss as well. Because Wernicke's encephalopathy, it can happen in a periodic manner or episodic manner. Multiple such episodes of multiple encephalopathy may leave breaches in memory of an individual. And because there are breaches in memory, the individual tries to bridge the story by creating artificial scenarios, which we call as confabulation. And if you ask an individual about any incidents, what has happened, he would give you a mix of real and imaginary stories, which sounds like psychosis. So hence hence it is named as Korsakoff's psychosis. So Wernicke's encephalopathy and Korsakoff psychosis, often in later stages of alcohol use, go hand in hand. Uh, Needless to mention that there would be progressive, gradual development of multiple cognitive deficits. Even alcohol induced dementia is seen. Many times in initial stages, it is reversible, but beyond a particular stage, it may be irreversible. After seeing the physical complications, it's important that we study a little bit about chronic psychiatric effects. We have known induced disorders because of particular substance. Alcohol has got a range of induced disorders, which include alcohol induced psychotic disorder, alcohol induced psychotic disorder, wherein individual gets delusions, fixed firm false beliefs, which are unshakable even if you give evidence to the contrary. There could be hallucinations, where individual gets a sensation of seeing something or hearing something when actually the thing doesn't exist. Usually alcohol induced psychotic disorder or alcohol induced any psychotic disorder disappear after 1 month of abstinence of alcohol. But of course there is a complicated relation which we may see in subsequent sessions as well. Alcohol induced mood disorder is also very, very common. So you see in individuals consuming alcohol presenting with depression or presenting with anxiety. Anxiety again is a very, very common comorbidity with alcohol, and many times alcohol can be the causal factor for having anxiety disorder. Apart from that, you also see alcohol induced sleep disorder. So initially there would be increased NREM and decreased REM sleep, but later on, as the alcohol use becomes chronic, wakefulness, distortion in architecture of your sleep, restless sleep, vivid dreams or nightmares is again common. Again, important and concerning for many individuals is sexual dysfunction. Alcohol does induce sexual dysfunction, and it's not just peripheral, not just organic, but also central. Because of its central effects, it causes impaired desire, impaired arousal, impaired orgasm, or sometimes sexual pain as well. Having seen this range of effects, physical, mental, we cannot complete this list without mentioning the socio-occupational and financial and legal complications of alcohol. It is often said that alcohol is not an individual disorder, it's a social disorder. It's a social ailment. So, alcohol does not affect just the individual who consumes it, but also the family around, the children, the spouse, the parents, the immediate community around, and society by large. So it causes stigma, it causes social isolation, it damages relationship, Not just that, there's problems with occupational functioning. So unemployment is very common, which again leads to financial troubles, and then indulgence in crime and legal issues leading to different litigations are commonly seen in individuals with alcohol. Many times abuse of the partner is again very commonly seen, and that is the way individual gets into legal complications or legal issues because of alcohol. Looking at a larger picture, it's not just an individual or community or society. There is work loss. There is problems with relationship. There is the health is at loss. The health of population is at loss. So, looking at a larger magnitude, you would see that alcohol does cause an economic burden on an overall society as well as the national economic scenario. Of course, this topic is exhausting. I would want to speak more, but I wouldn't take much more of your time. I would be inviting questions if time allows and if Dr. Parker allows, but I would want to end my presentation over here. Thank you. Over to you, Dr. Parker, ma'am. Ma'am, you're muted. Parker, ma'am, you're muted.
So, alcohol is a powerful chemical that can have a wide range of adverse effects on almost every part of one's body, including your brain, bones, heart. Thank you for such an elaborate presentation, throwing light on why alcohol requires to be treated. So, this is where we understand that how intense requirement is to treat alcohol. Now that our first panelist is there, should we go to the first talk? Dr. Rupali
Thank,
Shivalkar?
yes, thank you, ma'am. Good evening. Today I'll be talking
Yes,
primarily
so we
about,
will be continuing on the talk and understand, yes, understanding the magnitude and the core concepts of alcohol use disorder. Here to you, Dr. Rupali.
thank you, ma'am. Uh, Today I'll be talking about primarily defining this problem at individual level. Yes, it caused lot of problem, but looking at a larger perspective from a clinical paradigm, what is the magnitude of alcohol problem that we are dealing with? Can I have the next slide, please? Yeah, these are the topics that let's look at it from the clinical question of alcohol. So, looking at the magnitude, we all know that alcohol is one of the commonest substance and commonly accepted and popular substance that has been used across world. If we look at it, just looking alone for India, the consumption in last 18-20 years has increased from 2.5 to 5.5 liter per capita, and that's a huge consumption. We are also having this difficulty that whenever alcohol is taken, it is uh, it is not only the use, it sometimes lead to disordered use. If you look at the population, roughly 7% of the world's population is going for disordered use of alcohol, out of which 3.8% they say are actually dependent on alcohol. So, what is it that is causing this huge prevalence? In India, if you look at the prevalence of alcohol, it is roughly 5.2% to 12.5%, depending on the region. And what we recently seen that alcohol has not been only urban problem. If you look at post-COVID rise, it is primarily the rural areas of India which has shown very high increase in alcohol. Rajasthan, Madhya Pradesh have been the main ones. Also, what we see is the home consumption of alcohol increased. So, barring that one pandemic dip that had come in the lockdown, the alcohol has back with surge with almost 29% increase in its revenue as well as use. So, alcohol is going to be a major public health problem for all of us. It is considered to be the second leading cause for the years lived with disability. Now, that's a huge one. 1.5% of all our deaths are also attributed to alcohol. And if you look at this whole population, how many of them are actually reaching the treatment? If you look at it, it's only 1 in 5, that is less than 20%, genuinely use the treatment as an option. Now, there are many factors why it happens, including the economic crisis, the affordability of the healthcare, the lack of social support, but also important are the stigma. Particularly, women with alcohol use would not like to come to any center for de addiction. If you look, they are primarily, you might see them in gastroenterology or liver disease clinics than coming for genuine treatment for alcohol dependence. So that has been our problem. And is the problem of alcohol is only health? No, it is apart from health. As Neelam just said, Dr. Neelam just mentioned, it is the psychological, legal, interpersonal, relational difficulties, and overall decreasing quality of health that actually affects and makes this whole problem a major public health crisis. There are many people who feel that it is only the long term alcohol that leads to problem. But if you look at it, we all know the table that it is more than 80 percent or 80 milligram per deciliter of alcohol actually starts interfering with brain. So all those people who have been using very large quantities in short duration of time are also going to be a major clinical problem because their impact on brain is equally hazardous. So, what is it? When we look at the spectrum of alcohol use, we know that it is the social drinkers. There are people who use it regularly. There are people who has been using it in a harmful way. And there are people who have been actually dependent, who fulfill the criteria of alcohol dependence syndrome. So, clinically, when a clinician looks at it, it is primarily the two categories that we are more worried about: the harmful use pattern and the clinical dependence syndrome. The regular users, if the compulsive use is becoming the major criteria leading to difficulties, then that can come under harmful use pattern. So, harmful use is primarily any sort of alcohol use that is going to have a hazardous effect on your physical health, mental health. It can also have social, legal, and interpersonal complications. So, large quantities in short time, alcohol use in a hazardous situations, all will actually contribute to harmful use pattern. For it to be qualified as dependence syndrome, we say there are two criteria that are required: the compulsive use of alcohol, where the person may require large and larger quantities to produce the same effect of alcohol, and also if person abruptly stops or doesn't take alcohol or decreases the consumption of alcohol, it may actually result in the physical withdrawal symptoms, which can be simply the sleep disturbances, tremulousness, difficulty concentration, or it could be even complicated withdrawal like seizures or confusional states. So, this is the whole spectrum of clinically significant alcohol use disorders. In this, what I would like to pay more attention to is the binge drinkers. We always thought that binge drinkers are the ones which are more dangerous because it is the large amount. The moment the first sip goes in, the person is unable to stop. So, that compulsive need of alcohol till the person almost drops dead or is actually carried to the emergency, the person continues drinking. So, these are the areas where we need to look more into. And why does that happen in the first place? What is it that makes the compulsive drinking the necessity? So, if you look at the neurobiological pattern or the circuitry of alcohol, we all know that when you take alcohol for the first time, it is going to affect your reward system. So, through dopamine and opioid, it is going to give that pleasurable effect, what in psychiatry we call it as positive reinforcement. Now, this positive reinforcement, if repeats, continues, the brain is going to go through neuroadaptation. So, the reward circuit is going to be less sensitive now. So, to have the same kind of effect, the person may require more and more alcohol. This is what we call as tolerance. Now, this tolerance and the withdrawal effect is what is going to lead to distress. And any distress, your prefrontal cortex is going to get activated. Prefrontal cortex will send signals to anterior cingulate cortex and there to again reward system. So the emotional control and the control decision making, the overall control over actions, all which are governed by the prefrontal cortex are going to be affected because repeated stimulation in prefrontal cortex is going to lead to damage. Now that damage may result in what we call as classically the intense craving, the emotional discontrol, which leads to intense craving. And because there is a poor decision making, the person may not decide to not use. Person may actually give in, which leads to lapse and relapse. So this vicious cycle, if it continues, we realize that person has already lost that capacity to control. We say alcohol dependence is one of the disorder where person has good intellectual insight and yet the person is unable to stop because of this brain mechanism that is already functional. And this brain changes doesn't happen with only long term use. It can happen with any hazardous use. Even binge pattern of use, the changes can take place. So what are we saying? Are we saying that the person is losing control means it is disorder? But we always thought it was a habit, not a disorder. Then what is it? Probably maybe the first drink could be our choice. But there are a number of factors that can make us vulnerable to alcohol. If one goes into etiology, one can look at it. There are genetic predisposition. The family history, parents having alcohol consumption are actually make changes in your genes, and there have been genes identified which we know by now makes us more vulnerable to continued use of alcohol. Besides genetic factors, of course, the easy accessibility, the early exposure to alcohol, alcohol being accepted and sometimes even made glamorous as it is happening today, that can lead to early use. And we know our brain matures till the age of almost 20-25. So any early use before the maturation process is completed is going to cause changes in the brain, which will lead to a very bad outcome as far as alcohol use is concerned. Many people use alcohol as a self medication therapy. So people may use it for sleep, people may use it to handle their stress, people may use it to handle their breakups, emotional difficulties, as we have always seen. But all these factors are primarily leading to compulsive use of alcohol. And compulsive use is definitely a disease. We know that compulsive use, along with the physical symptoms of tolerance, withdrawal, just lets us know that it is a severity of alcohol that is harming the person. And because alcohol is making those brain changes, it is involving not only the structural changes but neuropathway changes. We have to consider it as any pathological disease that is happening in body. Alcohol will have definitely, as Dr. Neelam pointed out, multiple serious complications, not only for brain, for the entire body, but apart from that, socio-occupational functioning is also going to be affected. We all know emotional determinants are very, very important as far as our health is concerned. So any social drift downward is going to impact health adversely. So these are the things we feel that alcohol no more remains a habit. It is actually a part of a chronic relapsing disease which requires clinicians' attention. And why then we have to identify them early? Because we all know brain changes can happen anytime. So if one actually expects a better treatment outcome, one wants to have prevent the health complications, reduce the overall social impact, and have good effect on quality of life, wherein person maintains employment, stabilizes relations, then early identification and early intervention becomes our major responsibility as clinicians. How do we actually go for early identification? Since I've been a student, we have been taught that one small questionnaire, 4 questions just. We call it cage questionnaire. Have you ever tried to cut down on your alcohol? Have you ever feel annoyed by your alcohol use? Has there been any guilt associated with your alcohol use? And has there been any morning eye opening alcohol use? Now these are the simple clinical questions which may not take more than few seconds, but that can give us idea about the severity of use. Every use requires attention, particularly in high risk people, and I think using simple clinical questions can help us reach people who require help. Also important that it is not person's failing that if he fails to abstain, it is the brain network that is making it difficult for him to abstain. So rather than being judgmental, if we understand that neurobiology and try and help the person handle this, I think we are going to actually reach to a better solution. Can I have my next point, please? Next slide. I'll go for the next slide, please. Yeah. So all I would like to here point out here is yes, alcohol disorder is a major public health problem, which is actually responsibility of every clinician to look into, identify, intervene. Alcohol use disorder, as we call it, is primarily the problematic pattern of alcohol use, which essentially involves loss of control, any and significant impairment, which can be classified into mild, moderate, severe, depending on what DSM or ICD give it as criteria. Over last 12 months, 1 month has to be severe use of criteria. As it progresses, we all know alcohol can lead to brain damage, and therefore early intervention makes it mandatory. We know that those with prolonged abstinence can show some improvement in some of the parameters. It is the combination of genetic, environmental, developmental factors that are making person vulnerable to use alcohol. So probably not only biology, but psychosocial determinants and the factors which may be maintaining alcohol continued use are also required to be looked into. So, like any other chronic illness, we call it diabetes, hypertension, or even obesity, which we know by now are medical emergencies, major medical difficulties. Alcohol use disorder is also a chronic medical disorder which has a relapsing course and which requires early intervention. Thank you. If any questions, I will.
Yeah. Yeah, thank you, Rupali. That was a very nice presentation, because I think the lay people do not understand, not even sometimes doctor, what is the alcohol. Alcohol use disorder is very important disorder with a lot of pathology, and this needs to be identified as quickly as we can. Maybe every doctor, not just psychiatrists, from each field needs to understand the need of where the alcohol is becoming pathology, and they need to treat. So thank you very much. It was a very elaborate explanations, and we used to identify this as a biopsychosocial model, and this is a real model. There is a genetic on one side, there's a neurobiology, and there are psychosocial factors including personality. So we really needs to understand now that with such a magnitude, with so many complications, and threatening of the deterioration of the life, we needs to have the treatment for alcohol use disorder, which requires to be individualized based on the severity of the disorder, patient needs, comorbidities, and available support system. Management may range from brief intervention, outpatient counseling, to structured inpatient or residential treatment programs. So, for individuals with moderate to severe alcohol use disorder, as Dr. Rupali said, detoxification and withdrawal management, pharmacological intervention, including oral drugs, medication, psychosocial therapies, family involvement, psychoeducation, all this is required, and it is a chronic medical condition. So, treatment goals of alcohol use disorder are always dynamic and patient centered, evolving over the time. With this context, it's my pleasure to invite our next panelist, Dr. Milan Balkrishnan, who will speak on management of alcohol use disorder, anti-craving focus, and psychosocial management. Dr. Milan Balkrishnan is a consultant psychiatrist and psychotherapist and currently serves as the head of the Department of Psychiatry at Messina Hospital. He is also visiting consultant at Breach Candy Hospital and Bombay Hospital. He has held several important professional leadership roles, including ex secretary of the Bombay Psychiatric Society and ex managing committee member of the Association of Medical Consultants. In addition, he is trained in mindfulness based approaches, which add a valuable dimension to contemporary psychosocial management of substance use disorder and especially alcohol use disorder. We look forward to your insight, Dr. Balkrishnan, on integrating pharmacological and psychosocial strategies in the management of alcohol use disorder. Over to you.
Thank you, ma'am. First, of course, I want to thank Dr. Parker for having us, ma'am, for having us all here on the same platform. And more importantly, I think uh, both Dr. Rupali and Dr. Neelam have set the stage sort of beautifully from talking about neurobiology, neuroadaptation, complications, and sort of progressing to now how we can uh, manage uh, alcohol use disorders. And I think like they spoke, alcohol use disorder is typically like a chronic relapsing brain disease. I think that is something that we all should understand and remember, so that our approach towards substance use disorders in itself changes. Because we must remember that most patients with substance use disorders will rarely, in fact, visit a psychiatrist. They're more likely to end up at a gastroenterologist. They are likely to end up with a physician, with a general physician, and usually with, very often, with some physical comorbidity that they are dealing with. And like with substance use disorders, we know very well that the best time uh, to sort of strike is when someone is suffering from a medical disorder related to a substance use disorder. That's the best time and the best opportunity for the entire healthcare system to recognize a substance use disorder and to also start initiating treatment for it. So uh, to say that it's not up to the psychiatrist alone to treat substance use disorders. It's important that uh, all other specialities also take up the onus of treating alcohol use disorder. Like I was saying, that being a brain disease, that's the organ that we are treating, right? The brain. So we can very easily, when we talk to our patients, correlate and compare alcohol use disorders also to diabetes or hypertension, by establishing that this is a brain that's not functioning in the way that it should. And when it meets the substance, it leads to a lot of these complications and issues. So remembering that this will need a longer term treatment plan, which, and we need to be very patient with these patients. Like I think Dr. Rupali already covered this aspect of it not being a moral failure, not being a habit itself, but a medical illness and an illness of the brain. And it's not really a lack of willpower, but that alcohol affects our basal ganglia, which we talk about as the reward system. So it is like the go system creating the habit. It also rewires the prefrontal cortex, that is the one that is responsible for decision making. And so it creates poor breaks, just to sort of say that um, the basal ganglia makes you drive forward on your alcohol journey, and the prefrontal cortex not working effectively creates poorer brake mechanisms. So the alcohol journey goes on getting sort of goes on this path which is a downslope. And in addition to that, the part of the brain that's responsible for emotional responses, the amygdala, is also impacted, and which creates a sense of preoccupation. So that's typically what makes a person with an alcohol use disorder want to uh, plan that if I'm going for a picnic, I must carry my bottle along. I must make sure that I have all my alcohol in place. If I'm going to a friend's place or a party, I the anticipation is created that now I will have access to alcohol. So this is how sort of the alcohol and the brain works together to create this concoction of problems, right? So how do we how do we treat patients with alcohol use disorders? I'm not going to be focusing so much on the withdrawal line of management, because that is something that very often we are doing all the time, and we usually will do it with the use of benzodiazepines to manage the withdrawal symptoms, prevent delirium tremens. Those are all things that we must know. But what do we do in the longer term to sort of ensure that uh, a patient is free from alcohol, or not necessarily free, but that we'll also talk about, that we may also have to readjust our goals, that it doesn't always mean that we should focus on abstinence alone, which is the ideal clinical goal, where if we can achieve long term abstinence, of course we can help the brain recover fully. We can also help the other organs that are damaged, all the medical complications that Neelam spoke about. We could help reverse those as well. But still, even if we can't achieve full abstinence, harm reduction can also be a very valid and a life saving clinical goal. So, a person who's drinking a bottle full of whiskey, and if you're able to bring that patient down to drinking two drinks a day, you definitely reduce his physical risk. So his risk of ulcers, his cardiac risk, we will have reduced the level. What we can do when we encounter someone who is wanting to quit is to use the techniques that we call motivational interviewing. But very simply put, it is looking at what the person himself or herself understands about drinking, and how they can sort of recognize what are the difficulties that they face in staying away from alcohol. So it's good to ask simple questions like, what do you think are the good things related to drinking, and what are the not so good things that you uh, talk about? So this is actually sort of a way that we would often use for patients to start start their own internal dialogue and argument for change. So, motivational interviewing is a way of getting people to move in their levels of motivation to a place where they understand that I would like to quit, and I would like to work on quitting, and I develop my own reasons for the same, and we build on the reasons that the patient identifies, which could be uh, healthcare related, safety related, could be risks related to alcohol, and accidents could be a multitude of factors, and then sort of build on that and help uh, take the patient on this journey. Very important, especially in the Indian context, definitely very important, is to actively involve the family. The family is involved, but sometimes the family can be involved in a way that may not be supportive uh, to the patient. They may be accusatory, they may be argumentative. This may lead to, in fact, uh, unhealthy situations where quitting alcohol may become a bigger problem. So when we treating these patients, we need to train the family members to monitor not only treatments but create this effective supportive environment. And the best way to do that is by what I was saying, right? To remind them that it's not a moral failure, it's not a only a habit, it's not something that the person chooses to do. It is an illness and a disease of the brain. Reinforcing that medical model for the patient as well as the relatives is very important, because they both buying into this idea of um, the medical model is very important for our future treatment plan. Right. Now, while we would treat and support patients, of course, we would supplement them with multivitamins and all supportive medications. But the most important treatment modalities are anti craving medication. And it's very clear that anti craving medications are not only for the psychiatrist alone, they can be used by anybody with a medical qualification and can be used effectively. If we start using them and we develop confidence in using them, we will see definitely a change, and we'll start believing in ourselves that we can use these medications effectively. So the broad common ones that we use most often would be naltrexone, acamprosate, disulfiram, and then baclofen. Uh, the one that now, when do we use which one, right? So what is the group of patients when you talk to the patient, you know that this is a patient who is finding it very difficult to give up, is struggling with giving up, is constantly saying that I don't think I can stop because I can't sort of stop, I can't give up, and I have to go back to alcohol. Those are the kind of patients who will best benefit with naltrexone. So what, uh, simply put, when a person drinks, it triggers off, along with, in the reward pathway, we're also triggering off endogenous opioids, and the job of naltrexone is to sort of block the opioids mu receptors by competitively binding to them. So what does this do to the patient itself? It it makes him feel that the drink is not so enjoyable, it's boring. So that's how you want to explain to the patient that by taking this medication, you will not enjoy the drink so much, and hence you will not may not want to drink. So typically what it does is, because of the blockade, there is no enjoyment, the dopamine spike is missing. So after drinking one drink, he doesn't feel like going on to drink the other drink. And what is a very effective way to administer naltrexone, and we usually start with about 50 milligram, is to give it, uh, suppose the patient says that 8 o'clock is when I start drinking. So, and after 8 o'clock you can't stop me. Once it's 8 o'clock, I have to go and drink. So it would be helpful to advise the patient to start the naltrexone about an hour before that. So at around 7 p.m., ask the patient to take the naltrexone. That will help them at around 8 o'clock not feel that very strong urge. So it's best for those who don't feel like giving up. The other very commonly used one is what we call acamprosate, right? Acamprosate is uh, the dosage of acamprosate is very important. The most common problem is that uh, we end up underdosing patients on acamprosate. So typically, anybody who's more than 60 kgs should be given a dose of 666 milligram thrice a day, which is like 333 milligram tablets, which we typically get, two in the morning, two in the afternoon, two in night. The problem with this kind of the dosage is problem with the adherence, right? Because having to take a tablet 3 times a day can be hard for people. People may end up missing it. So give them a lot of suggestions in terms of always keeping it in the pocket, or keeping it just in just next to their plate just before they start taking their meals, so it's available to them immediately. um, how does it work? It basically, uh, al- when alcohol when we stop alcohol, there's a lot of glutamate release in the brain, which makes the brain very active, irritable, which is also part of what happens in a withdrawal. But this is like, some people, those who have uh, prolonged issues with their glutamate circuits, end up having uh, withdrawal symptoms even for many, up to weeks, and many weeks after quitting alcohol or stopping alcohol. So they still feel irritable, they still feel restless, which is what we call a post acute withdrawal syndrome. And this is the group, those who feel very restless when they quit, are the best ones for uh, acamprosate. Important to remember that acamprosate is the best for those who have serious liver dysfunction, very high transaminases, SGOT, SGPT is more than 3 to 5 times. Then the best choice is acamprosate, because it's completely renally excreted. But in those who have obviously renal issues, it's best to stay clear of acamprosate. And then we have, of course, disulfiram. Disulfiram is a works differently from the rest of these, because it doesn't work as much from an anti-craving perspective as it works as a deterrent. And how does it work? Basically, that when it inhibits the enzyme called aldehyde dehydrogenase, leading to accumulation of acetaldehyde when alcohol and disulfiram mix together. So the accumulation of acetaldehyde leads to the disulfiram alcohol reaction, the disulfiram ethanol reaction, which may look as very intense flushing, tachycardia, restlessness, hypotension, giddiness, sweating, even confusion and weakness. Uh, this makes people not drink on obviously consuming disulfiram, and the reaction being, the inhibition being long term, we get a lot of accumulation of uh, the acetaldehyde, and hence we can't it can't be it's not easy for people to sort of stop disulfiram and take alcohol quickly on it, because it will take at least a couple of uh, days before the fresh aldehyde dehydrogenase can be created in the liver. We need to always remind our family, who can be sometimes over enthusiastic, and this is fairly common in India, for uh, disulfiram to be available in powdered form for families to spike patients tea or food. So make sure that we forbid this, because if a patient drinks especially large quantities of alcohol and is unaware, and especially if he has a comorbidity, there's a risk that there may be a massive drop in blood pressure and tachycardia, and can even lead to myocardial infarction and death. Uh, so it's very important to address this. It's also important to address the hidden alcohol that's present in hand sanitizers, aftershave, cough syrups, even some Ayurvedic medications. So it's important to remind patients of all of this. Generally, we would look at the dosage as 250 to 500. Very rarely we may need slightly higher doses than that, especially in patients who seem to metabolize it more actively and hence may require higher doses. When very important, of course, to look at psychiatric comorbidities, and alcohol use comes with a lot, can be come with a lot of comorbidities, like we already discussed. Very common issues are anxiety, depression itself, which and where alcohol may become a sort of a self medication. The other Some of the other important comorbidities could be social anxiety, could be attention deficit hyperactivity disorder. These are comorbidities that need probably to be evaluated and treated. Definitely more likely it would be helpful to refer these this group to a psychiatrist because of the multiple comorbidities that are being managed. But it's also important to understand that we, especially during withdrawal, patients may appear to be very anxious, restless. That doesn't itself mean that it is a it doesn't mean that this is anxiety itself. Mood changes, depression also may be common during the early stages. Hence, wait for at least 2 weeks or longer before we decide that this person is off alcohol for 2 weeks, and then we can decide whether he or she also has depression or anxiety. Once the withdrawal phase is over, avoid uh, continuing to prescribe benzodiazepines, because we know that um, benzodiazepines can become substitutes for alcohol use and can lead to uh, people moving from alcohol dependence to benzodiazepine dependence. So be careful. If sleep remains an issue, you can use trazodone, mirtazapine, or quetiapine in low doses to help a patient sleep. Now, important to also register and remember that it's very important to call patients regularly for follow-ups, because we can't say, okay, you take these medications and you'll be fine, because the it's very important to check in between, because it helps the patient sort of uh, one reflect on what's happening in terms of why he or she is not able to stay away from alcohol fully. What are the barriers that he or she faces, what are the difficulties he or she faces, and even just a little motivational push can help patients stay actively away from alcohol use. Clearly, do not scold if a patient is not abstinent, because like I said, we are focused uh, on the idea that this is a biological model of illness where it's not only the patient or his it's definitely not only his willpower, it is the brain that we are struggling with. So assure the patient that no, okay, if one medication is not working, we may need a dose increase or we may need to change, and we may also need to look at other ways of working on motivation, increasing the barriers to access to the substance of alcohol. All of this can be rooted on every follow up, and we can enhance the support that's available to the patient. We must also, like I said, always support the family, help them be involved in the treatment, involve them very actively, and make sure that they are able to provide a supportive environment. We should treat regularly for at least a year or longer. It's important that we are supportive of the patient and their family, and we ourselves don't give up on the patients or family. That is very important, because that's something that happens very often in alcohol use disorders. There is a sense of frustration that things are not improving or things are not changing, but they may be based on our own beliefs that patients should improve fully, or patient should uh, not sort of relapse. So even if patients are abstinent for a while, we must also remember that there is always a risk of lapsing and relapsing, and we should also ready patients for that, and keep reminding them that we have to, this is a regular process that we need to sort of deal with, and we are going to sort of also wake up every day and remind them that we, each morning, that we are going to stay away from alcohol as much as possible. And it may also be helpful to uh, connect these patients to an Alcoholics Anonymous group, because that's a place where there is uh, a sense of support, a sense of um, sort of a feeling of brotherhood, and a peer support group that can be very helpful in terms of helping them not only realize that they can stay away, but also that um, everybody and a lot of people who are going through this journey are facing similar difficulties. Thank you. Am I muted?
To important to know that change is likely to happen when motivation comes from the patient, not just the clinician. And very nicely, very comprehensively, you have got these facts of treating the patient. And I think what is important is the kind of patience you showed while presenting. That kind of patience is needed while treating the disorder like alcohol. I would ask one question to each one of you. Um, uh, the first question which I would like to ask Dr. Milan is, when you give some these drugs like disulfiram, you need to take informed consent, right, from the patient, and
Yes.
a very intense counseling perhaps would be required for that particular purpose, right? Uh,
Yes.
yeah. The another thing which is very important is motivation enhancement therapy, which is, I mean, how often do you think it is being carried out? Which sounds so good. Yeah.
So that's why I think we need to sort of have more and more. And I think in the past also, ma'am, you conducted a lot of workshops for primary care physicians to in terms of working on motivational enhancement, as well as motivational interviewing as a part of uh, treatment modalities. I think that's certainly very important. But I think also, like, I just wanted to uh, reinforce that, it's very important that that the the doctor, the physician, has belief in this whole model, because otherwise there is always this sense of fighting a losing battle. So uh, like you said, a lot of patience, lot of making sure that we
Yeah.
we can ourselves sort of help this group of patients, and make sure that we are there supporting them through the process.
Absolutely, because we should be ready that they will keep coming back, and even at the age of 70. But we should identify this is a recurring disorder. I just wanted to ask Dr. Rupali that the kind of approach we take, it should be different for the for the women, for the adolescent, or for the elderly. What is your thought on this?
I think very true, ma'am, because it is not the same approach that works with everybody. We all understand that main alcoholism primarily come from genetic factors as well as the developmental or personality factors. When it comes to adolescent and women, the parameters are slightly different. What we have understood till now, women alcoholism has lot to do with emotional determinants. So it is the emotional health that matters. So classic model of de-addiction may not work there. We have to understand what alcohol is playing a role for that woman and how we can help replace it with something more productive or creative. When it comes to adolescent, there is now a new phase, the curious ones. So they are the ones who are actually experimenting with number of things. Unless there is some major risk factors in the background, be it the dysfunctional families or family history of alcoholism, the adolescent generation, our traditional approach of medicine doesn't work again,
Yeah.
because this is a
Yes.
new generation who are very curious. We need to
That is a
negotiate with them.
Gen Z. That is what they say.
And now it's Gen Alpha and Gen Beta
Alpha and
also.
yeah, yeah. So we are
So
waiting
it's
for
a
that.
lot
That's
of
right.
generations that have come, and I think their way of talking to them is probably more a transactional way. We need to make them understand if we are saying why alcohol is harmful, we need to explain them what it does to your brain, how it can impact your further creativity, and what are the other options for that dopamine release for you, because it is ultimately the dopamine release seeking that they are looking for. So I think as a clinician, we need to change gears the moment our patient changes.
Yeah. Yes, right.
Right.
Yeah, I agree. It's quite challenging. I'm coming to Dr. Neelam. You come from the public health background, so just tell us that what should psychiatrists do differently to reduce alcohol use disorder?
Uh, of course, it's a favorite question for me because I work uh, simultaneously for public health as well. Uh, I think today is the age of preventive psychiatry, and the approach is shifting from clinic-based mental health to community-based mental health. So when it comes to alcohol, nothing can replace uh, approach of controlling alcohol and the prevalence or epidemiology of alcohol uh, without preventing or falling into this trap of the spectrum that we saw in these sessions of harmful use, hazardous use, and then alcohol dependence. So early identification and early intervention. The intervention, as psychiatrists, I understand that we are at the apex of the pyramid where we could be the technical guide or technical support of how this could be percolated down to the community, about what is to be taught to the community, so that community does not fall in this trap of hazardous use, harmful use, and then dependence. How do we use resources at the community level? For example, many of us have been working with primary care physicians so that we built their capacity to have early identification and management at their level, like simple psychological interventions and simple medical interventions at the primary care level to address the issues, to reduce the harm, and then help people remit and then get cured, or get better from alcohol use disorder. So a community approach is indispensable when it comes to the next step for controlling alcohol use disorder in community.
Yeah, I think yeah, it's a very important. Thank you so much. All of you have really contributed. Very not so complicated. It was very simple to understand, and yet it has got a great public health weightage to change this scenario. Alcohol use disorder is a chronic relapsing condition, much like diabetes or hypertension. Relapse is not failure, but it is a signal to review treatment and strengthen support, time and again. For non-psychiatrist physician, early screening, safe withdrawal management, routine thiamine supplementation, avoidance of abrupt alcohol cessation, and timely referral to a psychiatrist are key clinical responsibilities by which we can really change the life of the patient as well as the family and therefore the community. With empathy, vigilance, and collaboration, clinicians can significantly reduce morbidity, mortality, and relapse in alcohol use disorder. And this is where I feel we really need to have the patience and great frustration tolerance, because this is the field which will challenge us time and again, and do whatever best we can do again and again, till our patient and till our community start getting the message that this is not something good for the quality of the life or the productivity of the life, and it is physically or pathologically harming to one's individual and to the society in general. Thank you very much. It was a really nice session, nice listening to all of you, and I hope the doctors who are attending this particular panel will be satisfied. If there is some questions, they also can ask the questions. Arpita, so we have completed the uh, panel.
Thank you, ma'am. Thank you so much. It's over time, so we'll not like extend it more. And if there are any questions, we would like to go for another session, maybe in the near future. So thanks to everyone. Thanks to Dr. Parker, ma'am, for leading the session so well, and thanks to all our panelists for giving their valuable time. So with that, I would like to conclude the session for today.
Thank you.
Thank
Thank
you.
you.
Thank you. Thank you.
Thank you so much.